speaking on electroconvulsive therapy and different facets of the therapy. He is the author of a monthly column on the subject electroconvulsive therapy in Journal of Clinical Psychology since 2012. That long contribution, and an expert in research methodologies, including statistical methods. And you would also be interested in listening to about his other hobbies like classical music and poetry, freelance journalism, athletics, and high altitude mountaineering. So, with a rich experience and expertise, we have Dr. Chittaranjan Andrade, professor from NIMHANS, for this talk on electroconvulsive therapy. Professor Chittaranjan, welcome to you, and over to you. Thank you so much for accepting this invitation of the Academy for delivering a talk this afternoon. Dr. Andrade, please.
Thank you, sir. Am I ready to start?
Yes.
Yes, sir. Please start, sir.
My slides are visible. My voice is audible.
Yes.
Sir. Both clear, sir.
Good afternoon, everybody. And my apology if we are a little late this afternoon. There were some technical difficulties at our end, which seem to have been resolved now. My presentation is on electroconvulsive therapy, abbreviated to ECT, which is a treatment method in psychiatry that has been available for more than 80 years. This presentation, I realize, is for a non-medical audience, and so I will try and make it as simple as possible. The slides are not changing. Just a minute, there is some technical problem again. Sorry, the slides were not changing. The slides were not changing, and I think that the problem is, at least I hope that the problem is solved. In this presentation, I will be talking about myths and misconceptions about ECT. I will provide reliable information about ECT, and I will discuss the science underlying ECT. Even though ECT has been available for more than 80 years, as I told you earlier, it is a very much misunderstood treatment, and there are a lot of adverse remarks about ECT that emerge in, for example, movies, on television, in newspapers, in magazines, and even in everyday conversation, even in hospitals, besides in the general community. So what is ECT? I told you ECT is electroconvulsive therapy. There are three elements: electroconvulsive and therapy. Electro means electricity is passed through the brain. Convulsion means a seizure is produced. By seizure, I mean something like what you see when you see an epileptic fit occurring in a man who may have fallen at the side of a road. Treatment means that this seizure induced by electricity which is passed through the head actually produces benefit. So electroconvulsive therapy means the elicitation of an epileptic fit or seizure by the passage of a very small current through the brain of a patient who has a major mental illness. And this seizure elicited by electricity results in patients with major mental illness actually getting better. What do I mean by major mental illness? I refer to conditions such as severe depression, that is major depressive disorder or bipolar depression. Then mania, which is another psychiatric disorder. Schizophrenia, which is another psychiatric disorder. The catatonic syndrome, which is a kind of psychiatric illness which occurs in different medical and psychiatric disorders. And even in neurological disorders, ECT has been found effective in Parkinson's disease, in patients with epilepsy, in patients with tic disorder, and in patients with autoaggressive syndromes. Now, I told you that the use of electricity in ECT is associated with much misunderstanding in movies, TV, newspapers, and other media. Now, why is this? If you pass ECT through the head, it seems to be a barbaric form of treatment. The use of electricity makes people think of electric chair, which was used in the execution of prisoners on the death row in countries like the USA. Then the use of electricity to elicit a convulsion. A seizure is something which is an illness in a patient. Epilepsy is an illness. So if we are inducing a seizure, aren't we inducing something that we don't want to induce? An epileptic seizure. The very name electroconvulsive therapy, sometimes abbreviated to shock treatment, sounds unpleasant. Nobody would want to receive a treatment where electricity is passed through the brain, where a seizure is part of the treatment, where shocks are given, and so on. So sensationalistic journalism distorts what ECT actually is. ECT is actually a very, very safe treatment, a very, very effective treatment as practiced today. ECT is also irresponsibly depicted in movies, on TV, and distorted by anti-ECT lobbies in countries like the USA. There is very much misinformation about ECT in movies. For example, many of you would have seen the old movie, One Flew Over the Cuckoo's Nest. Very famous movie, won a lot of awards. Many of you would have seen Hindi movies like Jewel Thief, Raat Aur Din, Khamoshi, and so on. Again, movies in which ECT has been shown in a very bad light. This is a paper which I wrote on the depiction of ECT in Hindi cinema. Now, myths about ECT are many. People think that ECT is an outdated treatment, which is not. ECT is practiced even today all over the world, not just in countries like India, but also in countries like the US, the UK, and other Western countries. People think that ECT is used as a last resort when nothing else works and the patient is severely ill, not responding to medication. Well, this is true. ECT is used as a last resort, but ECT can also be used as a first-line treatment, as the choice of treatment, the most effective treatment in patients, for example, who are suicidal, in patients who are very severely ill, in patients who need to get better quickly because ECT works like magic in a lot of patients. Then there is a myth which is that ECT is used as a punishment. This is absolutely untrue. ECT is never used to punish mentally ill patients. It's never used to punish bad behavior in anybody. That is something that is depicted in movies, which is absolutely fictional. ECT is indeed used to treat violent patients, but not as a punishment. It's used as a treatment to treat violence or aggression against self, autoaggression, but as a way to reduce symptoms of mental illness. ECT is never used to treat uncooperative patients. ECT is not a treatment for lack of cooperation. Then people believe that in ECT, large currents are passed for long durations. Absolutely untrue. The current which is passed in ECT is something like, say, 0.8 amperes. It's a tiny current compared to, say, the 5 amps and the 15 amps which you get in the electric circuits. And people think that ECT is passed for a long duration through the brain, like maybe for 15 minutes or 30 minutes. Absolutely untrue. The electricity in ECT is passed for something like half a second, rarely for more than 1 second. Then people think that ECT is painful and that the patient is conscious during ECT and so experiences pain. Absolutely untrue. ECT is absolutely painless. And ECT is not given to a conscious patient. We give anesthesia to a patient before ECT so that the patient is actually sleeping while current is passed through the brain. Like people think that ECT makes people lose their rational capacity, their logical capacity, their volitional capacity, and the patients become like zombies after ECT. Absolutely untrue. Patients actually recover and become normal after ECT. People think that ECT causes brain damage. This is a persistent myth which has been propagated by the anti-ECT lobby. In fact, an enormous body of research conducted across decades shows that there is absolutely no evidence of brain damage occurring after ECT. And yet another myth is that nobody knows how ECT works. This is not true. There is a large library of evidence, research evidence, on all the changes that take place in the brain after ECT and how these may benefit patients with major mental illness. In fact, I will, if time permits, show you some slides of work which we have done in our own department and in collaboration with other institutes, showing how ECT may work in patients with depression. So how did something like ECT start? Who got the idea that passing current through the head to produce a seizure would make patients with major mental illness better? The story goes back to 1934, where a Hungarian psychiatrist called Meduna, he observed that in his mental hospital, patients with schizophrenia rarely had epilepsy, and patients with epilepsy rarely had schizophrenia. So he thought that there was some kind of biological antagonism between epilepsy and schizophrenia. More importantly, he observed that when patients with schizophrenia had epileptic seizures, as rarely is possible, they actually got better. So he thought if patients who experience spontaneous seizures due to epilepsy improve after the seizures, maybe if I produce seizures in these patients, their schizophrenia will become better. Now, you must understand his thinking. This was in 1938 when there was no treatment available in psychiatry. Patients with major and minor mental illnesses had no treatment available. 100 years ago, there was very little treatment available in other branches of medicine as well. Pharmacology and psychopharmacology developed only in the last 50 to 75 years. For example, lithium as a treatment for bipolar disorder came in 1949, chlorpromazine for psychosis in 1952, and imipramine to treat depression in 1960. So in 1938, there was no treatment available for major mental illness and psychotic disorders like schizophrenia. So what did Meduna do? In 1934, he used camphor in oil to induce seizures. Later, he used intravenous pentylene-tetrazole to induce seizures. Now, how did he know that these cause seizures? Because in animals, when these treatments were given, seizures were elicited. So he injected in 1934 a schizophrenia patient with camphor in oil. The patient had a seizure and the patient became better. And he injected the patient with another dose of camphor in oil and the patient became still better. He did this with other patients as well, and all the patients became better. Now, the problem with giving camphor in oil is that when it has to be given intramuscularly. So when it's given inside the muscle, it takes time to be absorbed. And if it takes time to be absorbed, the seizure occurs after 15 minutes or after half an hour. And it's very unpleasant for a patient to wait for half an hour, knowing that he's going to experience a seizure. It's very awkward for the doctor to stand at the patient's bedside for 15 minutes or half an hour, waiting for the seizure to occur. So von Bedunga used intravenous pentylene tetrazole, which produces a seizure much faster. But again, over here, things like dose issues come into play. What dose of pentylene tetrazole should you give? If you give one dose, the patient may not have a seizure. If you give a higher dose, the patient may have a seizure which goes on and on and on and on for 5 minutes or longer. And long seizures are associated with more problems, medical problems, and even potential complications. So, Serletti and Binney, two neuropsychiatrists in Rome, they had observed pigs in the slaughterhouse being stunned by the use of electricity before the pigs were slaughtered and later sent to the butchers. So they figured out that if electricity can stun pigs and produce seizures in pigs, maybe electricity can be used in humans as well. Initially, they experimented with dogs and perfected their technique. And in 1938, the first ECT was administered to a schizophrenia patient in Rome. At that time, electricity was sinusoidal wave, the kind of electricity you get in the electricity mains in your houses. So they administered 110 volts. We have 230 volts over here in our 220 to 230 volts over here in our electricity mains. So they administered a current with a voltage of 110 volts for a duration of 0.2 seconds. The patient had a seizure, the patient became better, they gave ECT to more patients and the patients became better, and that's how ECT was born. Now, more than 80 years have passed, and although many other kinds of treatment, somatic treatments have been used in psychiatry, ECT remains the only somatic treatment to have survived the advent of psychotropic drugs, that is, medicines to treat major mental illness. The reason why ECT is still used today is that ECT is a gold standard treatment. Compared with medicines, ECT is associated with better outcomes, and ECT comes closer to giving a guarantee card that the patient will recover with treatment. As an example, drugs are poorly effective in a condition called psychotic depression, but ECT is associated with a 90% cure rate in patients with psychotic depression. ECT is particularly effective when certain symptoms are present, like, for example, psychotic symptoms or catatonic symptoms. ECT is associated with a very rapid onset of response. With drugs, for example, patients may take 1 month, 2 months, 3 months to recover. With ECT, very often within 2 weeks. Rarely longer than that, maybe 4 weeks. The patient is all right and normal. ECT is associated with very high remission rates where the patient makes a complete recovery. And ECT is also very useful in special circumstances, such as when a patient is severely ill, or when the patient is suicidal, when the patient has catatonic symptoms, when the patient has not responded to medicines. And now ECT becomes the last resort treatment. Now, I need you to understand that ECT is done after careful medical evaluation. ECT is practiced in a very scientific manner in modern medicine. The psychiatrist will do a complete physical examination on the patient, a complete neurological examination. ECG is done, X-rays are done, blood tests are done. All this is done to ensure that the patient is fit not only for ECT, but fit for anesthesia. Why do we give anesthesia before we give ECT? Because we don't give ECT to a conscious patient. We give ECT to a patient who is sleeping because it is far more humane. So anesthesia requires certain tests to be performed, and these include the ECG, the X-ray, the blood tests, and so on. And ECT, these tests are also done to make sure the patient has no problems, say, with bone or with muscles or with any other part of the body, because ECT does produce some amount of stress to the physiological systems. Please note that there are no absolute contraindications to ECT. ECT can even be given to people with heart disease. ECT can be given to a person who has recently had a heart attack. ECT can be given to people who have neurological disease. ECT has even been used as a treatment for certain neurological diseases like Parkinson's disease, tic disorder, dystonia, and so on. The risk-benefit ratio needs to be assessed for every patient before ECT is given. So what do we do when we give patients ECT? We evaluate the patient the previous day or the previous 2 or 3 days, doing all the tests and the physical examinations and so on. Then on the day of ECT, we keep the patient fasting overnight. Why should the patient be fasting? The reason is that anesthesia is given. Anesthesia requires a patient to be fasting for 4 to 6 hours, sometimes longer than that. So we bring the patient after an overnight fast into a special room. ECT is not given in a ward or in any common or public place. ECT is given in a special room or in something that is called an ECT suite. There is a waiting room in which the patient waits before he comes into the ECT room. There is the ECT room in which the patient is given the ECT. There is a recovery room in which the patient recovers after the ECT and so on. So when the patient comes into the ECT room, the first thing that is done is that the patient is ventilated with pure oxygen. The reason is that a seizure is produced during ECT and the patient does not breathe during the 30 seconds or 1 minute that the patient has a seizure. So the patient is given pure oxygen so that his lungs and his blood cells are full of oxygen before the ECT is given. Once the patient is hyperventilated with pure oxygen, anesthesia is given. Anesthesia puts the patient to sleep. Then a muscle relaxant is given. The muscle relaxant relaxes all the muscles of the body so that when the patient has the seizure, actually the body does not jerk. If you have seen a patient having an epileptic seizure, you would have seen that the patient falls down at the side of the road and there's a violent jerking of the body that lasts for 30 minutes, 45 minutes or longer. With ECT, this jerking of the body is prevented by the administration of a muscle relaxant. So the ECT looks a lot more humane than what is depicted, say, in movies or on television. So anesthesia is given, the patient is sleeping, muscle relaxant is given, the patient does not experience jerks as part of a convulsion, and an anticholinergic drug may sometimes be given to make ECT safer for the heart. So I told you that ECT is given in an ECT suite, which has a room in which the patient wakes, a room in which the ECT is given, and a room in which the patient recovers. I told you ECT is given with pre-medication that comprises anesthesia, a muscle relaxant, and sometimes an anticholinergic drug. I told you that ECT is given after the patient is hyperventilated with 100% oxygen. ECT involves hyperventilation even during the seizure. So even after the current is passed, the patient continues to be hyperventilated with 100 pure oxygen to increase the safety of the procedure. A little piece of rubber is placed inside the mouth during ECT so that the patient doesn't accidentally bite his tongue. The current which is passed is very tiny, I told you. I mentioned that Sir Letty and Binney used 110 volts stepped down current for 0.2 seconds. Today, we don't use sine wave current. We use something called brief pulse current, where something like 0.8 milliamperes of current are passed for something like 0.4 or 0.8 seconds. And the pulse frequency may be something like 62.5 hertz or 125 pulses per second. And the width of each pulse is something like, say, 0.5 milliseconds or 0.75 milliseconds. So you can see that the actual amount of total current passed through the brain is very tiny. In patients with depression, we may give something like 60 millicoulombs of charge, or maybe 120 millicoulombs of charge in the entire ECT process. This is a very, very, very tiny quantity of current, and certainly not lightning bolts of current as may be depicted in movies. During ECT, the pulse is monitored, blood pressure is monitored, ECG is monitored, EEG is also monitored, so that the seizure is monitored. So you can see that with ECT, a lot of safety procedures are in place to make sure that the procedure is absolutely safe. While the patient is recovering, the patient continues to be ventilated with pure oxygen until the patient starts breathing normally again. Why does the patient stop breathing during ECT? You remember I told you we inject a muscle relaxant. The muscle relaxant prevents the jerking of the body during the seizure. The muscle relaxant also prevents breathing. So the patient needs to be ventilated by the anesthetist who is present during ECT. And the ventilation is done with pure oxygen until the patient starts breathing on his own again. This usually happens in about 3 or 4 minutes. And the patient recovers consciousness soon after. So the entire procedure lasts maybe 3, 4 minutes, 5 minutes at the most. The current is passed for a fraction of a second. The seizure lasts for a few seconds, 15 seconds, 30 seconds, rarely longer. And the patient starts breathing and recovers consciousness because the anesthesia wears off in maybe 3, 4 minutes, rarely beyond that. Then the patient who has recovered consciousness is moved into the recovery room, which is the third part of the ECT suite. And somebody stays with the patient until the patient recovers completely and is able to get up and walk and talk and move about normally. So this usually happens after another 10 minutes or 15 minutes. The patient is a little sleepy after the ECT, but that's natural because anesthesia has been given. And the anesthesia completely wears off after about 15 minutes or 20 minutes, after which the patient becomes completely normal. Well, normal in the sense, not that his mental illness goes away after one ECT, but normal in the sense that he recovers a normal level of consciousness. He can walk, talk, and eat and drink and do whatever he normally does during the course of the day. So the patient moves to the ward after that happens. So this is the way ECT is given. To remind you, what is the strength of the current administered during ECT? It's very tiny, something like 0.8 amperes. For what duration is the current passed? For a very, very tiny period, something like 0.4 seconds or maybe 0.8 seconds, rarely longer than that. How often is ECT administered? ECT is administered not several times a day, not every day. ECT is usually administered on alternate days, thrice a week, like for example, Monday, Wednesday, and Friday. And how many ECTs should a patient be administered? Not 50 ECTs, not 100 ECTs. Most patients require just 6 to 8 ECTs to recover completely from depression. 6 to 8 ECTs, just that, in 2 weeks or 3 weeks to recover completely from depression. I told you that Serletti and Binney use sine wave ECT. That is the kind of electricity you get in the mains, sinusoidal wave current. They use 110 volts for 0.2 seconds. In the old days, 30, 40 years ago, everybody used to use sine wave ECT, and common parameters were 120 volts for 0.5 seconds. Today, we use brief pulse current because with brief pulse current, much less electricity is passed. And I told you that the amplitude of the current is only 0.8 amperes. And ECT is passed for maximum 1 second, 0.4 to 0.8 seconds, rarely more than 1 second. I also told you the width of the pulse can be 0.5 milliseconds, 0.75 milliseconds, rarely more than 1 millisecond. And the frequency of the pulse is 62.5 hertz. That means per second there are 125 pulses rather than current being continuously passed. The charge that is delivered is commonly in the region of 60 to 120 millicoulombs to begin with, but across the course of the ECT, the seizure threshold increases, so patients may require maybe around 100 to 300 millicoulombs of charge for a seizure to be elicited. Now, here are some technical issues. Research has found that higher electrical doses, for example, 300 millicoulombs, elicit faster recovery and come with a better guarantee card of recovery than lower electric doses like 100 millicoulombs. This kind of makes sense. You feel better if you're eating a full meal than if you're eating a half meal. You do better if you receive a higher dose of a painkiller than if you receive a very low dose of a painkiller when you have a headache, and so on. ECT can be given unilaterally. In other words, I should have told you this earlier. For ECT to be delivered, electrodes have to be placed on the head. So the current passes from one electrode to the other electrode through the brain, but also through parallel circuits in the scalp. Now, ECT, the electrodes are usually placed on the temples on either side of the head, right? You know where the temple is, it's at the side of your head. Now, that is called bilateral ECT. ECT can also be given unilaterally. That is, one electrode is placed on the right temple and the other electrode is placed on the top of the head, right on top, in the middle. So this means that only the right part of the brain is stimulated. Now, speech and memory associated with language belongs to the left part of the brain. That is the left cerebral hemisphere. So if electricity is passed only through the right part of the brain, that is the right cerebral hemisphere, memory tends to be spared. Sorry. Memory is spared and the side effects of ECT become less. Unfortunately, unilateral ECT may be less effective than bilateral ECT. Unilateral ECT is associated with fewer side effects, but is also associated with less efficacy. Also makes sense. If you take a lower dose of painkiller, there is less benefit, but there is also less risk of side effects with the painkiller. I told you that ECT is usually given 2 to 3 times a week on alternate days. So it usually takes 2 to 3 weeks for the patient to receive 6 to 8 ECTs. Some patients may receive fewer ECTs, like 4 ECTs. Some patients may require more ECTs, like 10 to 12 ECTs. 6 to 8 ECTs is commonest. Now, treatment does not stop after ECT is given. Patients require maintenance medication with antidepressant drugs or antipsychotic drugs so that they remain well. ECT produces improvement, but patients must remain well for weeks or months or years after that. And for that, ordinary psychotropic medicines, antidepressants or antipsychotic drugs are required. If patients do not respond to maintenance medicines with antidepressants or antipsychotic drugs, they can receive maintenance ECT. That is, ECT can be repeated once a week or once in 2 weeks or once a month until the patient, as long as the patient requires the ECT to stay well. Now, nothing in life comes without strings attached. Even if you cross the road, you are at risk of somebody knocking you down, right? So what are the side effects of ECT? Just as medicines may have side effects, ECT also has side effects. The side effects of ECT can be due to anesthesia, can be due to muscle relaxant, can be due to convulsion that is produced, or can be due to the electricity itself. People think that ECT may be associated with the risk of death. This is a myth. Death due to ECT is very, very rare, occurs in 1 in 50,000 or 1 in 100,000 ECTs. This means that ECT is safer than getting pregnant, because pregnancy and delivery is associated with a much higher risk of death than ECT. Then patients who take medicines can have an overdose and die of overdose if they are suicidal. But patients cannot commit suicide with ECT. So ECT becomes particularly useful in suicidal patients, not just because patients can't commit suicide with ECT, but because ECT produces a very rapid remission of suicidal thought. Other rare side effects are fractures of bones, dislocations, dental problems, etc. See, after all, during ECT, a seizure is produced. And during a seizure, there is violent jerking of the body. The patient can bite the tongue. The patient can bite the jaw so tight that the teeth break. A joint can be dislocated, like a shoulder joint can be dislocated. Bones can get fractured because of the violence of the seizure. This does not happen. This is rare, even with spontaneous seizures in epileptic patients. It does not happen with modern ECT because we give, remember I told you about the muscle relaxant? We give a muscle relaxant which prevents the jerking of the body, which prevents a violent seizure, which makes the procedure very, very humane, which makes the procedure safe from an orthopedic perspective. ECT can produce confusion in about 5 or 10% of patients. The confusion occurs after the patient wakes up following the ECT, and the confusion is most commonly due to an inadequate dose of anesthesia. If you give a higher dose of anesthesia the next time, the patient sleeps for a longer period, and when the patient wakes up, there is no confusion. Some patients experience headache or body ache after the ECT. This is not due to the seizure. This is not due to the electricity. This is actually due to the muscle relaxant. When patients recover from a muscle relaxant, they may experience body ache. Then patients may experience cognitive disturbances, particularly memory disturbances after ECT. And this is a real problem. I'm not saying that the problem is so severe that we shouldn't give ECT, but it is the most important problem associated with ECT. ECT is associated with amnesia. Amnesia means forgetfulness or impairment in memory. And the amnesia can be of two kinds, anterograde amnesia or retrograde amnesia. Anterograde amnesia means if the patient learns something, he forgets it very quickly. Like if something happens during the course of ECT, the next day the patient has forgotten it. This is actually very mild and quite rare with ECT. Retrograde amnesia is more common. The patient forgets what happened the previous day, the previous week, and so on. Retrograde amnesia is more distressing because sometimes patients forget things that happened, say, 1 year ago or 2 years ago, which is unhappy because memories are precious to us, isn't it? Happily, retrograde amnesia is also mild with ECT. Retrograde amnesia is mostly for the period that the patient was mentally ill, for the period the patient was in the hospital. And retrograde amnesia tends to wear off, so maybe 3 months or 6 months later, the patient recovers most of the memories. Unfortunately, what happens is that ECT is very often blamed for the forgetfulness in everyday life. See, all of us sometimes forget where we left our keys, where we left our spectacles. All of us forget somebody's name. All of us forget an address or a phone number. All of us forget what we learned in class yesterday. And most of us remember very little of what we learned in class last week. If we received ECT, we would blame this ordinary forgetfulness on ECT, not realizing this kind of forgetfulness is part of normal life. So I think I've been speaking for about 45 minutes. I will see what else is important. Let me wind up with a few slides on mechanism of action of ECT. I told you that there is a huge amount of research that has been conducted on the mechanism of action of ECT. We know what ECT does to different chemicals in the brain. We know what ECT does to physiological potentials in the brain. We know what ECT does to proteins in the brain. We know what ECT does to cells in different parts of the brain. The only thing we don't know is which of all these changes is responsible for the benefit. And part of the problem here is that ECT is the only treatment which is available for so many different kinds of mental illness. Otherwise, medicines are specific to illness. For example, antidepressant drugs work only for depression, antipsychotic drugs work only for psychosis, and so on. Whereas ECT works for depression, for psychosis, for mania, for tic disorders, for epilepsy, and for so very many different conditions. So some of the research that we have done over here in our department in collaboration with other institutes are on the changes that ECT produces in the brain. We can't do this in humans, obviously, because we can't dissect a human after ECT, but we can do it in laboratory animals like rats. Now, this is a part of the brain called the hippocampus. Now, in the hippocampus, you have nerve cells, and these nerve cells have branches. How dense the branches are is important because a nerve cell with more branches can connect to more other nerve cells, making the brain more connected. So if the brain is more connected, it's good. If you know a lot of people, it means you have a lot of connections. You are socially powerful. The same way, if a nerve cell has a lot of connections in the brain, that's good. It makes the nerve cell more powerful. It makes that part of the brain better functioning. So there's a part of the brain called the hippocampus. It is situated in the temporal lobe, that is at the side of the brain, on the left side and on the right side. And the hippocampus has nerve cells called neurons. And these nerve cells have branches called dendrites. So here is a slide, a picture of a slide showing a section of the hippocampus. You can see nerve cells with branches. The nerve cells are the dots and the branches are all the black lines that come out from the dots. So these rats received sham ECT. That is, ECT was given, but no current was actually passed. You can see that the nerve cells don't have very many branches. But here, this rat received low dose ECT, a low current, only 10 millicoulombs of charge. And you can see there are a lot more branches from the nerve cell than in the rat which received sham ECT. Very few branches here, a lot more branches here. And this rat received high dose ECT, 40 millicoulombs of charge. You can see how much more branching there is, how much more crowding the branches appear. So the connectivity of the nerve cells in the hippocampus is much, much better over here than it was in animals, in the rats that received sham ECT. Now we also looked at the number of new nerve cells in the hippocampus. Remember, the hippocampus is the seat of learning and memory in the brain. There's a hippocampus on the left side, there's a hippocampus on the right side. So here is a hippocampus where I wonder if you can see it well on your screen. There are a few dots, dark brown dots, which show new nerve cells which have been stained in rats which receive sham ECT. In rats which received low dose ECT, you can see a lot of more dark dots, meaning that more new nerve cells here than in rats which received sham ECT. And in rats which received high dose ECT, you can see lots of dark dots, meaning that there are lots of much more new nerve cells being formed in the hippocampus of rats which received high dose ECT. Why is it important to have more branches? Why is it important to have more new nerve cells forming? I told you the hippocampus is the seat of learning and memory. So if there are more nerve cells, if there are more branches of nerve cells, the connectivity of the hippocampus improves. And so learning and memory is potentially improved. Now, in patients with depression, coping is poor. Patients need to learn how to cope better. patients need to learn how to adjust better to stress. So if there is more dendritic arborization, this means more branching of nerve cells. If there is more new nerve cell formation, which means more neurogenesis, it means that the hippocampus in these brains allows the organism to adapt better to the environment and to cope better with stress. The same mechanism can explain forgetfulness with ECT, because if the connectivity of the new nerve cells, the new branches, disturbs existing connections, then existing memories can be disturbed. So this is a very elegant hypothesis to explain how ECT not only produces forgetfulness, but how ECT improves learning, improves coping in patients with depression. Now, here is something that happens in a part of the brain called the amygdala. The amygdala is also present on the left side of the brain and the right side of the brain. The amygdala is a little nucleus situated next to the hippocampus in the same part of the brain, the temporal lobe that I spoke to you about. I told you the temporal lobe is present at the side of the brain. The amygdala is important because the amygdala is associated with fear learning. For example, if somebody shouts at you, you learn to associate that person with unpleasant sensations. That learning takes place in the amygdala. If you touch a hot pressure cooker and your hand feels pain, a burning pain, you learn how not to touch anything that is hot again because it's associated with pain. And that learning takes place in the amygdala. We looked at what happened to the amygdala of rats which received sham ECT and rats which received low and high dose ECT. On the left side, you see the amygdala of a rat which received sham ECT. There are a lot of branches. On the right side, in the middle, you see the amygdala of a rat which received low dose ECT. There are a lot of branches here also. That big triangle at the top is the nerve cell. And on the right side, you see the amygdala of a rat which received high dose ECT. And you can see the big triangle, which is the nerve cell, with actually very few branches of the apical dendrite. Right? There are very few branches, there's very little branching. Now, this means that ECT may have produced a lot of branching in the hippocampus, which we want, but it's actually suppressing branching in the amygdala, which is also what we want. Because patients with depression are anxious, they are afraid, they remember a lot of unpleasant memories. So when the branching in the amygdala is reduced, all these unpleasant memories are reduced. The patient does not forget the memory. The memory itself is associated with the hippocampus, but the patient forgets the fear which is associated with the memory. So the memory no longer is unpleasant, and the patient is able to think of that unpleasant event without experiencing the fear or the anxiety or the depression associated with the event. So this also is an elegant way of explaining how ECT works in patients with depression. We also did electron microscopy studies which showed that inhibitory synapses are these little circles which you can see. The rectangles are the excitatory synapses. So you can see that there are a lot of excitatory synapses in the amygdala of a rat which has received sham ECT. There are fewer excitatory synapses and more inhibitory synapses in a rat which received low dose ECT. And you can see here there are more circles and even fewer rectangles, indicating more inhibitory synapses and fewer excitatory synapses in the amygdala of rats which received high dose ECT. So there is more inhibitory synapses, meaning the activity in the amygdala is reduced. the fear which the amygdala mediates is reduced in patients who have received ECT. So in the bottom line is there is no convincing evidence that ECT produces brain damage. ECT, in contrast, actually produces more nerve cell formation and more branching out of nerve cells, which is part of the mechanism of action of ECT. There is strong evidence that ECT may be the most potent inducer of these favorable brain changes, even greater than the benefits that are observed with the administration of antidepressant and other drugs. And these changes occur in important brain territories. ECT is not an outdated treatment. It is not used as a last resort. It can be used as a first-line treatment in severely ill patients. It is not used as a punishment. It is not used to treat violent or uncooperative patients. The current used in ECT is not large. It is small. It is not, current is not passed for a long period. It's passed for a fraction of a second. The patient is not conscious during ECT. The patient is asleep because of anesthesia. ECT is a painless procedure. ECT doesn't make patients behave like zombies. ECT makes them normal. ECT does not cause brain damage. ECT actually promotes neurogenesis, new nerve cell formation in the brain and branching out of nerve cells in the brain. And we do know, at least we have a lot of good ideas about how ECT works. A lot of patients who have received ECT say that they are more afraid of going to the dentist than of receiving ECT. So you can see that ECT is very much a safe and a humane procedure as practiced today. So with that, I conclude my presentation. If there is time for a question and answer session, I hand over the session back to the chairperson.
Good evening, sir. It was a very informative and scholarly talk on ECT. We got to know many things that we did not know about ECT. Now the session is open for few questions, if there are any. Umesh? Mr. Umesh?
Yes, sir. As of now, there are no questions, sir. We have requested participants to mention in the chat box.
Yeah.
If anybody wants to speak with sir also, then we can unmute them.
Yeah. Sir, one question I have. Is ECT to be given periodically or once for a certain period it should be given and stopped?
So ECT is usually given in a course of 6 to 8 treatments. It is given on alternate days, like Monday, Wednesday, Friday, Monday, Wednesday, Friday. In other words, alternate days 3 times a week, and very commonly given for 2 weeks to 3 weeks. So in 2 to 3 weeks, 6 to 8 ECTs are given. ECT is given until the target is met. The target is usually the patient should recover, or the patient should at least attain maximal recovery. So it takes about 6 to 9 ECTs, rarely more than that, 10 to 12 ECTs for a patient to either recover completely or to plateau with no further improvement occurring after that.
Yes, sir.
Now, for depression, patients require 6 to 8 ECTs on average. For schizophrenia, patients may require more ECTs, like 10 to 15 ECTs. So it depends upon the condition. So for some conditions, fewer ECTs, some conditions, more ECTs. For some target symptoms, fewer ECTs. For some target symptoms, more ECTs, and so on. Then, if a patient recovers completely, ECT is usually tapered and stopped. Otherwise, if the patient keeps relapsing because medicines are not working, ECT can be given once a week or once in 2 weeks or even once a month, so that the patient continues to stay well with treatment. See, we need to continue to breathe to survive. We need to continue to eat food every day to stay healthy. We can't eat a meal today and say eat a meal for the next 2 weeks and say for the rest of my life I don't need to eat any more food. So sometimes it happens that for ECT also we need to continue for a longer period. That is called maintenance ECT. But most commonly, ECT is given for 6 to 8 ECT treatments, and that's it. No more treatment is required. Medicines are given after that. The patient remains well.
Thank you, sir. Umesh?
Yes, sir. There are few questions.
Please continue. Please ask Umesh.
Sir, yes, sir. Is incomplete ECT treatment will create more complications in future, sir?
No, by incomplete ECT treatment, I assume you mean that instead of giving ECT until the patient recovers, we give ECT until the patient merely becomes better and then we stop the ECT. Well, there is no harm at all. There's no harm at all in giving, say, 3 ECTs instead of 6 ECTs. But the point of giving ECT is to make the patient recover. Why would anyone give ECT and stop after the patient has only benefited partially? So, if medicines didn't work before ECT, why would they work if only 3 ECTs or 4 ECTs have been given? So while there is no harm in stopping ECT prematurely, there is no purpose in giving an incomplete treatment either.
Thank you, sir. There is one more
It's
question.
not like let me just continue.
Yes.
If you give antibiotics for only 2 or 3 days instead of the full course of 5 to 7 days, microbial resistance can develop, which is bad. So if you give for too short a period, it can be harmful. But if you give ECT for too short a period, there is no harm done.
Thank you, sir. Sir, whether ECT is better than using antipsychotic drugs in your opinion, sir?
So there is controversy about this. ECT produces faster recovery than antipsychotic drugs. But ECT doesn't produce better recovery than antipsychotic drugs. So ECT is not usually given for psychosis or to patients with schizophrenia. ECT is more commonly given for depression because depression can be associated with suicidality or depression can be medication refractory. ECT is given to psychotic or schizophrenic patients only if the patient is not responding to medication. And we have lots of different medicines for psychosis. So ECT is not commonly given for psychosis. So if you're comparing ECT with antipsychotic drugs, I would say, let's use antipsychotic drugs first. Actually, even for depression, I would say, let's use antidepressant drugs first, unless the patient is, say, suicidal or catatonic and so on. The same also applies to schizophrenia, I suppose. There are some situations in which you would prefer an antipsychotic drug and some situations in which you would prefer ECT.
Thank you, sir. There is one more question, sir. Does ECT make changes in brain waves?
ECT produces changes in different chemicals in the brain. See, nerve cells communicate with each other across gaps called synapses through chemicals called neurotransmitters. ECT raises the levels of some chemicals, lowers the level of some of these chemicals, neurotransmitters. ECT increases the number or density or sensitivity of proteins called receptors, which are situated on nerve cells and to which these chemicals or neurotransmitters bind. Then ECT changes membrane potentials, changes EEG patterns, changes the communication patterns between different parts of the brain. ECT produces more nerve cells, it increases branching out of nerve cells. So there are lots of changes that take place in the brain after ECT. But these changes are favorable changes. They are not unfavorable changes. These are changes that we want to see in patients with depression or patients with schizophrenia. None of these changes represent brain damage.
Thank you, sir.
Thank you very much, sir. I am immensely thankful to Dr. Chittaranjan Andrade, sir, for a very scholarly and illuminating talk on electroconvulsive therapy, myths and facts. In fact, sir gave a very basic information about ECT technique and its various applications in psychiatric patients. And your talk was very simple for us to understand, sir. We understand that ECT is very safe to use and it's being used even today. And many myths about ECT have been busted with your talk. In fact, I'm very glad to inform the participants that Professor Andrade sir is among the top 2% of the world scientists. Hearty congratulations, sir. We are very happy to have you for this talk. And I take this opportunity to thank our Honorable Chairman, Dr. S. Ayappan, for guidance and helping us in organizing this program. In fact, he had to leave a little early because of his earlier commitment. And also, I thank our honorable member of KSTA, Dr. A. Eknath, who was there due to some technical problem. He had to leave early. I am very grateful to Dr. Bharat Srinivas, who gave us the contact of Dr. Andrade sir. And we are very grateful to you, Dr. Bharat. Are you there, Dr. Bharat? Thank you, sir. Bharat sir. And I acknowledge the presence and also thank our senior faculties who are present on this occasion. Dr. Shakuntala Samuelson, Dr. Sita Lakshmi, Dr. S.R. Ramesh, Dr. Ravi Kiran, Dr. Gauramma, Dr. Shivanand, Sri Nagesh Aralkuppe, Dr. Sumaya Tabassum. My special thanks to Dr. Tabassum for helping us in organizing this program, and Dr. Sanat Kumar and Ms. Shamala Kumar. I'm immensely thankful to Principal of Surana College for her help in organizing this program. We are very grateful to you, sir. We'll be organizing many specialized program for PG students of science, in which we'll be inviting you for talks in future as well. We are grateful to you, sir. Thank you very much.
Thank
Thank you,
you.
sir. Sir, there
Thank
are a few more questions coming now. Shall we take it or we can take it offline? Sir?
I
If, sir,
I-
yes, sir, yeah, please continue. No problem. If there are many questions, any
Sir,
questions.
okay, sir. Sir, can ECT be effective for epilepsy?
ECT is not given as a treatment for epilepsy. The reason being we have a lot of excellent anti-epileptic medicines which the patient can take just by swallowing a pill in the convenience of his house. Why would he come to the hospital and receive ECT for epilepsy? Taking a tablet is much more easy. However, there is a condition called status epilepticus, where the patient has seizures which continue for hours and sometimes for days, and which don't stop even if anti-epileptics are given intravenously. In these patients, ECT can be given, and ECT has helped terminate status epilepticus in such patients. The reason why ECT works against epilepsy is that even though ECT produces a seizure, over course of time, ECT raises the seizure threshold, making it more difficult for patients to have subsequent seizures. So ECT can be given for status epilepticus to stop seizures progressing for hours to days. We have reported one patient who was having 5 to 10 seizures a day and who was poorly controlled with medicines, who received ECT and for nearly 2 years was almost seizure-free because he was receiving maintenance ECT. So whereas ECT is not a treatment that is recognized for epilepsy, in rare circumstances, ECT can have benefits for seizures.
Thank you, sir. When is the time the doctor decides for what condition the patient should be given ECT, sir?
So when the patient is brought to the psychiatrist evaluates the patient. How severe is the illness? Does the patient have any emergency symptoms like suicidal risk, which need to be urgently dealt with? Has the patient recovered with the help of medicines before? Has the patient taken medicines now, and is the patient benefiting with medicines? So the doctor evaluates the patient's diagnosis, evaluates the severity of illness, evaluates for the presence of special symptoms, and then chooses whether this medicine or that medicine or some other medicine may be desirable for the patient, or whether medicines may not help this patient at all and perhaps ECT is the best treatment. So it's usually at the first session that the doctor makes a decision. However, if a doctor prescribes medicines and the patient does not improve with medicines, and the patient is still seriously ill or suicidal, or the patient is not responding to multiple medication, then at that point in time also ECT can be offered as a potential treatment. So the decision can be taken at the first consultation, or the decision can be taken at later consultations, depending on the symptoms and depending on the response to medicines.
Thank you, sir. One more last question, sir. Neuronal remediation in hippocampus occurred after how many hours or days after giving ETC, sir? ECT?
So the formation of new dendrites can be observed even within a day or two after ECT, but the formation of new nerve cells is usually observed 2 weeks to 1 month after the ECT is given. Because it takes a little bit of time for new cells to be formed and for new cells to differentiate and for the cells to take up the stain, which is a dye, which is injected into the living animal. So the animal must live for some time after ECT, for the stain to be absorbed, for the stain to be distributed to the brain, for the stain to be taken up by the new nerve cell which is formed. So this usually does not happen for the first 2 weeks. We need to do it to sacrifice the animal 2 to 4 weeks later and then examine the brain. So new nerve cells may be formed early, but we can only detect them after a couple of weeks or longer.
Thank you, sir. Sir, last one more question, sir. Sorry to continue. The difference between the brain dead patient and terminally ill patient, sir. People would like to know.
Okay, this is not related to ECT at all, but I will answer. A terminally ill patient can be anybody. For example, I can be terminally ill right now if I have serious cancer, which has spread to my lungs, to my liver, to my bone, to my brain. Maybe in another 2 weeks, I may die. So I'm still conscious. I'm still aware of what is happening around me. I'm still able to talk. So I may be terminally ill, but otherwise I'm okay. Of course, many terminally ill patients are kept under sedation because they are in severe pain. Many terminally ill patients are also unconscious because of the nature of their illness, like say a head injury or say coma associated with chronic renal failure. But many terminally ill patients are conscious and you can talk to them. They'll be very depressed, of course, because they know they're going to die. In contrast, a brain dead patient is a patient who is breathing or maybe kept alive using a ventilator, and a patient whose heart is beating. So the patient's body is alive, but the patient has no awareness of what is happening around. If you talk to the patient does not respond. There is not even any change in the EEG in the brain if you speak to the patient, because the patient's brain is not registering any changes in the environment. In other words, there is no activity happening in the brain, and the EEG in this patient is flat. So it's the body that is alive, but there's no activity in the brain. The patient is brain dead. So the patient is being kept alive only artificially through food being given through pipes or through drips, or by a ventilator keep making the patient breathe and so on. So this is the difference between somebody who is terminally ill and somebody who is brain dead.
Thank you very much, sir. Still the questions are pouring. We will take it offline, sir. Thank you very much, sir. And a few participants attended from various districts and states, sir. From Delhi, few people would like to have your email ID for future communications, sir.
You can share my email ID, and
Yes, sir.
unless you have time limitations, I'm willing to answer questions if there are still questions.
There are 2 questions we can take, sir. Why ECT is not given or prescribed for all patients at first instance if it's more effective?
The reason is that ECT is more effective only in special circumstances, like patients who have psychotic depression, patients who are suicidal, patients who have certain special symptoms called catatonic symptoms, and so on. In a lot of other patients, drugs are just as good, and drugs, that is medicines, are far more convenient than ECT. For ECT, the patient has to come to a hospital after fasting, or the patient has to be admitted to the hospital, and this has to be given on alternate days, thrice a week. There's a lot of bother associated with it. It's much more convenient to just take a medicine every night at home. Much more convenient to take medicines at home than to take ECT in a hospital. So we would much rather take medicines to treat depression or schizophrenia or other conditions than ECT. So only if there's a real need for ECT, like it's an emergency or the patient is very severely ill or the patient hasn't responded to medicines and so on, only then we consider ECT as a first-line treatment.
Thank you, sir. How inhibitory and excitatory synapses in amygdala are identified, sir?
So these are identified on electron microscopy under something like 10,000 to 30,000 magnification. So in light microscopy, magnification may be 10x or 40x or 60x, 60 times magnification. With electron microscopy, you get 10,000, 30,000 magnification. So it depends upon the shape of the synapse. If the synapse is flattened, that synapse is an excitatory synapse. If the synapse is more circular, that synapse is an inhibitory synapse.
Thank you, sir. Is there any treatment for hot water epilepsy, sir?
Yes, avoid hot water. Simple, avoid hot water on the head. Patients can also take anti-epileptic medications, but the best treatment is to avoid pouring hot water on the head. Hot water epilepsy is triggered by the pouring of hot water on the head. The patient can have a body bath and can bathe the head with cold water. The patient can have a body bath with hot water, pour hot water on the body, but for the head, pour only cold water or bathe with cold water.
Thank you, sir. The last question I would like to take here and wind up. Is ECT helpful in the case of brain hemorrhages and brain tumors, sir?
Is ECT?
Helpful
No. ECT is actually not given to patients with brain tumor or brain hemorrhage. It's not given to patients with brain tumor because when ECT is given, there is increase in blood flow through the brain because the heart beats faster. And if there's increased blood flow through the brain becomes more congested. Now, the skull cannot expand. So if the brain gets more congested because there's more blood flowing through it, then the brain tends to be pushed downwards if there is already a tumor in the brain. If there is no tumor, there is space inside the skull between the meninges which cover the brain for the brain to expand, for the blood vessels to expand. But if there's already a tumor, then the available space is now restricted and expansion cannot occur. And so a part of the brain may be forced downwards through the skull. The medulla oblongata can be forced downwards through the skull. And if this happens, then the respiratory centers in the medulla don't work well, and the patient may stop breathing, and death can occur. So ECT is usually not given to people with brain tumors. And ECT is definitely not a treatment for brain tumors. For brain tumors, surgery is necessary or chemotherapy or radiotherapy is necessary. With regard to brain hemorrhage, hemorrhage means bleeding. Brain hemorrhage is also called hemorrhagic stroke, bleeding into the brain. We prefer not to give ECT to patients who have recently have a brain hemorrhage because ECT causes the heart to beat faster, it increases blood pressure very transiently, maybe for 15 seconds or 30 seconds. But during these 15 or 30 seconds that the heart is beating faster or the blood pressure goes up, the hemorrhage can recur in the brain if the bleeding blood vessel has not healed completely. So we wait for several weeks to pass after a brain hemorrhage before we think that it's safe to give the patient ECT. And then again, we give the ECT after giving antihypertensive medicines and medicines to slow the heartbeat, to ensure that the blood pressure doesn't go up, to ensure that the patient does not hemorrhage again. So there are a lot of medical precautions that we take in patients who receive ECT, depending upon the kind of illness that the patient has.
Sir, what about Alzheimer's people or Alzheimer patients can be diagnosed with this?
No, ECT is not used for Alzheimer's disease. In Alzheimer's disease, the nerve cells die out and the patient loses his thinking capacity. So eventually the patient becomes progressively more forgetful, progressively less aware of surroundings, progressively less capable of looking after himself. ECT cannot treat Alzheimer's disease because nerve cells are dying all over the brain in patients with Alzheimer's disease. ECT can only produce a limited amount of new nerve cell formation and branching in only one part of the brain, the hippocampus. So if nerve cells are dying all over the brain, there's nothing that ECT can do about it. ECT is not a treatment for Alzheimer's disease.
Thank you very much, sir. Such a wonderful and informative session, sir. Over to you, sir. Ramesh, sir.
Thank you very much, sir, once again for your very distinguished and scholarly talk. We are very, very grateful to you for accepting our invitation and for being with us for more than 1 hour. We will be inviting you for future talks also. Thank you very much, sir. Here is an announcement. Tomorrow, there will be a talk by Padma Shri Dr. V. Prakash, former director of CFTRI. He will be speaking on role of food, nutrition, lifestyle in enhancing immunity. I request all the participants to join tomorrow by 11 o'clock. I thank all participants for being with us since morning. We are thankful to you. And secondly, one more talk by Dr. Dhaval Shukla on brain tumors is being organized on 19th of this month. That's on Saturday. You may join that session also. I will share the poster to you all. Thank you very much. Thank you, sir. Thank you very much, sir.
Thank you.